And then they have counselors, case managers, and then triage accordingly. So there's no treatment with Project Response. It's just screening and testing.
Okay, well, that's very important. Okay.
And it's a free service for our patients. So, for example, they come on Fridays to one of our clinics and provide free testing. And we have banners hanging in all the exam rooms for anybody who would want to go, and then we refer patients who need to go.
Okay, I see. So, and are they concerned that all of their funding is going to go away, or it's just that it's going to be reduced?
I don't know the details of it, but I think that comprehensive health is struggling to make ends meet as it is, and felt like any other budgetary impact would be detrimental to their survival.
Okay, so they were coming
They're
to
also
you.
a very small organization, and their major leaders are reaching an age where they may not be able to continue, and so where to turn over the baton, they look to us.
Okay, I see. So, yeah, they're really making sure that their patients are going to be taken care of no matter what happens, so they came to you. Okay. All right.
Okay, then, if you don't mind, maybe we could start going, starting with question 4, we could start going through the assessment document. This is Mona speaking. And I noticed the names, you have chosen 3 providers that might participate as part of the care team, and 3 registered nurses, and 1 social worker is case manager is listed on the back. And the LPN MA column was empty, and I'm wondering if that's because you don't use LPNs and MAs, or there were none that you thought were appropriate for this program?
We just didn't feel like that was appropriate for the team. Remember, we're not doing this at all, so we wanted to start with the key providers and their immediate supports to start this.
Sure. Okay, and we can talk about that. And if I read the application correctly, there are about 12, at least, prescribing clinicians who might have been eligible. But you've selected these ones, or they've self-selected in terms of their own interest, or how were these chosen from among the your full set of staff?
One provider has interest and experience in HIV care, Dr. Graff. Deb Yesowich, nurse practitioner, takes care of a large portion of our homeless population. She works on our mobile unit.
Great. Okay. So then we could go on, and I noticed question 5 and 6 that you very correctly categorized yourself as external care model and foundation stage in terms of where you would start in terms of integrating HIV into your training. So that's good. And we also, we covered the response that you had put to question 7. We pretty much covered it in your very good introduction, because I really was wondering what the relationship of comprehensive health was, and now that's very clear. You mentioned that you haven't had, question number 8, is you haven't had much in the past year relationship with your AETC, but you did mention that there are two possible people who might be available to help with clinical mentoring, and one is from Comprehensive Health, and the other is from Project Response.
Yes.
So and both of them have you feel HIV experience that could guide you.
Oh yeah.
Okay, so when we're working with you on the training plan, we'll be extra careful to be sure that they are included wherever it would be appropriate.
Both those people and the organizations that they represent, all they do is HIV care.
Oh, wonderful. Okay, good. So honestly, we can skip some of those questions, as you said. If you're not dealing with the ATCs, then some of those questions about mentoring and all didn't really apply. So we could go on to the section about training plan development, which is one of our major concerns. And you mentioned that on one morning a week, one morning a quarter, a Friday morning every quarter, you have a pre-existing provider meeting that might sometimes be available to use to do some HIV group training. Is that correct?
Absolutely. We also have a second meeting with the providers as a group, not mandatory. The provider meeting is a mandatory meeting, but we have something we call it a brain trust, but we meet every other month. And most every provider except for 2 participate in it. And it's really an opportunity for us to improve the care that we provide, to look at evidence-based standards. And so certainly we could, you know, and we usually pick one disease process each time, so that we could pick HIV and spend a whole brain trust of looking at our program and doing some learning.
That would be a great opportunity. Yeah, I think that was mentioned in your application. On question 17, and something that is of interest to us, certainly when we're doing the HIV clinical training plan, is you thought that for the group training there would be less than an hour a week, and also for the self-study there would be less than an hour a week that people would be able to devote to it. And it's quite a comprehensive HIV training package, and you know, maybe when we do have our second call and we really talk in more depth about it, we could explore with you what the time constraints of your staff might, if that might present some kind of barrier, as you mentioned here, in getting that full set of training done in a reasonable amount of time. We usually think about a 1-year time frame.
I think the way that we would have to address this as an organization would be to have key individuals that are trained initially, do a train-the-trainer, because we can't expect to have experts on HIV management at all 6 of our clinics and the mobile unit.
Right, and so you're thinking about the 3 that you selected as starting with those 3.
I think we need to have a core team, and with those we certainly can carve out more time specifically to work on this training project.
Right, and even your core team would have less than an hour a week.
We might be able to expand that.
A little bit more, yeah. Good. Okay. Oh, well, essentially, honestly, if you only have an hour, I would like to let you have an opportunity to spend a little more time with the people from PCDC, because they have a larger set of questions, and we have a follow-on call that Christine will just take a minute to go over the next steps in clinical with you, one of which is, if you would be available, the opportunity to participate on the second call. There's one scheduled for Monday coming up.
So, yeah, we're having another call just to go over the HIV training package and the self-assessments. And I think I emailed you, Dr. Pinsky, last night a PowerPoint just going over the HIV training package. I would just review that prior to the call, and if you can't make the call, you can just contact us, and we'll answer any of your questions. And hopefully that'll give you a little bit more background about the clinical offerings and expectations and things of that nature.
What I have.
Is that for the clinical folks?
Yeah. Yes. I mean, specifically the clinical learning leader, but if there are other care team members that can and want to join, that's wonderful. So you Dr. Pinsky, you don't have to explain it again to somebody else. So we're offering 2 times, Monday at noon or Tuesday at 10. And again, if you can't make either one of those calls and still have questions after you review the PowerPoints, so just give us a call and we'll see what else we can do to speak with you.
Well, one more thing is that we have a second part of the clinical assessment, and that's one of the reasons that I can afford to be very brief today, is because we have a self-assessment form, a self-assessment process, and if you review the PowerPoint, you'll be able to get an idea of how that self-assessment fits into the development of an assessment-based HIV training plan. And I wonder if it would be possible. Do you think that you would like to receive those self-assessment forms also in advance of the call, so if you're going to be on the call on Monday, so you could have a look at what's involved? It's a bit of a lengthy process to fill out those forms.
You're talking about the HIV training package, and I'm...
Yes, I am.
Okay, and I've read through all of that. So what would the because we know that we are on the far end of the spectrum for not providing services when I went through your package. So I'm not sure what a self-assessment, even a lengthy self-assessment, how beneficial that would be for us, because we have no structure for this.
Okay.
We are a blank slate.
Okay, so would it make any sense to go through and say what you wanted to learn about? Because that's what it is. It gives you the opportunity to say, I don't know anything about this essential HIV clinical skill, and I would like to have it in my training plan. Or we can just take a shortcut and assume, that you would want to have almost everything.
Yes.
Oh, shortcut. Okay, I'm all for shortcuts.
Shortcuts are great.
and there is a foundation self-assessment, and there's a core set of about a dozen foundation skills, and that's not as lengthy, and I think it might be really worth it for you to have a look at that. We'll talk.
Skills over. Right.
Send it to under Susan Pinsky. Send it to myself. Megan, do they have yours?
Yes. And I'll only send you the very early stages of it, and we have a comprehensive table of what all the proficiencies are laid out by foundation, stage 1, stage 2, stage 3. And all you have to do is, it's kind of an at-a-glance thing, and so I'll send that to you because you can just see what you don't have to bother filling out, but you can still get an idea of the comprehensiveness of the training package. I'll do that before I leave today. Mm-hmm.
Do you have Megan Pierce's email as well?
I don't know.
Yes.
Okay.
So Megan and
3 of us: Susan Pinsky, Lisa Gurry, Megan Pierce.
Okay.
Yep. We have each of your email addresses.
Okay, then I'll make sure to do that. And are there any questions? Because I really would like to turn it over. It's a little bit longer part of the call. I'd like to turn that over to PCDC as soon as I can.
What do you tell? You use lots of acronyms, and we're not familiar with them. What is PCDC?
I'm sorry. It's the Primary Care Development Corporation. There are partners that are going to be helping help support the clinical training through performance improvement activities. So as you see, the second part of the assessment dealt with quality improvements, improving revenue, and population management and access. So those are the activities that the Primary Care Development Corporation will cover. And I'm sorry, with the AIDS Education Training Center's National Center for HIV Care in Minority Communities is such a long title. That's why sometimes we abbreviate it to the ATC NCHCMC. So if you ever hear us using an acronym, please stop us. We've worked with people in the South, and we have friends in the South that say, what were you just, a jargonometer?
They suggested that we use a jargonometer, so that all the times that we use jargon down there in Mississippi that people up here take for kind of common usage, that we would get points off and over the top on the jargonometer. So we apologize for using that. But Mazdak and Vanessa, who introduced themselves at the beginning of the call, they are the two people who are representing PCDC today.
Okay.
Yeah, sorry.
Okay.
Just call jargon when you hear it.
All right. And Mazdak and Vanessa, sorry, we were having some technical difficulties with the assessment, and Lisa and Dr. Pinsky and everybody at Brevard and Megan, we typically have the assessment up so that you can see what section we're reviewing at the time. So Mazdak or Vanessa, would you like to get started without the assessment visual?
Sure, and we have the assessments in front of us. So this is Mazdak speaking from the Primary Care Development Corporation. So if you need me to slow down since you don't have it in front of you, or if you have any questions, please stop me and ask a question. Vanessa and I are going to trade off asking you some questions around performance improvement, and we're very excited to be a part of this project. As Christina and Mona mentioned, I think our partners over there in DC really thought this through well, and as you all probably know very well, recognizing that working on clinical goals, and clinical improvement can't happen in a vacuum. And oftentimes issues such as workflow and access issues that fall more along the dimensions of performance improvement, if they aren't tackled at the same time, those clinical objectives, clinical goals often can't be met. And so we're really here to ask you some questions over the next 25 minutes now. We'll try to be quick to find out how we can best support you in the performance improvement realm in order to be able to be equipped to take on those patients from comprehensive health if for some reason they're not able to see as many patients, or if something happens with their funding. And I just want to say also that what you all are experiencing in Florida right now is kind of a trend in some other parts of the country too, especially with the President's National HIV/AIDS strategy. There's this movement towards being able to handle more people living with HIV and AIDS within primary care settings versus sending everybody to infectious disease specialists that are in Ryan White funded organizations. So I think you all will hopefully be on the cutting edge and can teach other folks a thing or two when it comes time for that in other areas as well. So do you have any questions before we get started with revenue maximization?
No.
Okay. So for revenue maximization, so for most of the folks that are in a foundational phase like you are, we're talking about working with them to do more testing, HIV testing or universal testing within their health centers. Can you talk to me a little bit more about Project Response, and are they handling all the HIV testing within your center?
Yes. Well, no.
No. Some of the HIV testing we send patients to labs. Some of the HIV testing we send them to the public health department, and some is Project Response. It's the only free and very quick resource that we have for patients, and they get immediate feedback.
Okay, great. And so that's it's either if they ask for it or they get asked by a provider if they want an HIV test, then they get referred to the Project Response folks that are there on site. Is that correct? You don't offer it universally for all your clients?
Not at this point. I mean, we offer it, but we don't necessarily specifically tell patients to go get it done. Okay. But anybody who wants it can access it.
Gotcha. And do you happen to know your seropositivity rate of the folks that you all test? How many folks are positive?
I don't know the rate. I would have to check with Project Response and the tests that they do. But I can anecdotally tell you that I don't know that any of us have had any patients that are positive at this point. And I've been here a year and a half. And usually we would talk about that as providers together.
Great.
Because that would be a very big clinical issue for us.
Okay. And if comprehensive health cannot handle their current patient populations, or do they do testing right now, comprehensive health?
Yes.
They do. So would you all would Project Response be able to pick up the extra demand in testing, or would that be something that you all would be interested in picking up internally?
Well, I mean, you mean if the future eliminated comprehensive health, would we pick up universal screening? No, because we would only screen our patients.
Oh, I meant universally screening all of your patients versus, it's stepping up, so basically making it the norm to test all your patients versus having them ask for a test or having the physician ask them for a test, just basically making the norm be we test everybody unless they tell us that they don't want to be tested.
Well, you know, it all depends on if Project Response retains their funding, because some of their funding is Ryan White as well. And so if all of these political factors are going to play into making that decision, so I don't know that we can answer that. If Project Response is still strong, then we would coordinate our efforts with them.
Mm-hmm.
Could we financially, at this point, take on universal testing? No.
Okay. And then in terms of, would you all be interested, or what is your level of expertise currently towards figuring out how to maximize the revenue of seeing more or any HIV positive patients for their care?
Well, I can tell you that because we're an FQHC, we receive the encounter rate billing for Medicare and Medicaid, which is an enhanced rate based on cost, as you know. And most of these we also have counselors in each of our clinics that get individuals on the qualifying programs like Medicaid and Medicare. So whether they were disabled or whether they had Medicaid or qualified and needed to go through the process, we would be involved with that, facilitating access to those programs. My understanding from Comprehensive Health is that 95% of their patient base do have Medicaid, Medicare, or private insurance.
Okay.
The private practitioners in Brevard County don't even deal with AIDS. We understand that what's happened is that as soon as that diagnosis is made, is they are all sent to, even if they're fully insured, to Comprehensive Health because they don't want to be burdened with the elaborate protocols to support HIV-positive individuals.
Okay. That's going to be quite a loss then if Comprehensive Health has to close its doors.
It is.
Yeah. Okay. And in terms of the rejection rates of your claims, it seems like that's pretty low. Is there any support you all feel like you need around claims being rejected?
Well, I can tell you we don't even know what we don't know about processing claims for this disease because we haven't done it.
Do you feel like Comprehensive Health would be available to give some support around that?
Billing?
Yeah. For how? Because I know state by state it's a little bit different, so it's nice when you can have someone who's doing it.
I think if there continues to be a challenge, what we've agreed is to meet on a regular basis and sort of keep up with how each other is doing in this area. So, yes, I believe that they would be supportive of helping us in any of these areas.
Okay. Well, thank you. I mean, I think the quick and dirty, I think I got as much information as I wanted from that section. I'm wondering if you all could speak to what do you feel like is the greatest need of your health center around the area of revenue maximization, particularly in working with this population.
I think understanding what Medicaid covers.
Okay.
Understanding if they cover for case management or behavioral health for these individuals, as well as what do they cover with this diagnosis for medical. How often can you see them? And then in Florida, dental is subcontracted out between two different entities. And so I would think once you've got them on Medicaid, they would qualify for the dental programs, which are very poor, though, because it only pays for emergency Medicaid in adults. So I would just like to know more about in Florida what they cover.
Okay. And then also, I know the AIDS Drug Assistance Program in Florida currently has a waiting list, so probably more information about what's covered in terms of drugs, too.
Right. That's what we were just talking about.
So it has a waiting list?
It does in Florida, yeah.
So who manages that drug assistance program in Florida?
I believe it's the state. Do you guys know over on?
Yeah, it's the state.
So that's something we can. So that is something we can prioritize for you all, depending on where else we land, is to get that information to you.
That'd be great, and also the reimbursement streams for individuals that you can get on Medicaid or Medicare. How often can you see the patients? What drugs are covered? Are all the top tier drugs covered, and behavioral health reimbursement?
Okay, great. Thank you. Vanessa, do you have any other questions for revenue maximizations before you go into quality improvement?
No, I think we covered it.
Okay.
The only other piece for the revenue maximization is what reimbursement is there for specialty care. If we acted as their primary, which is really all the piece that we bring, What about consulting with infectious disease or such? What programs pay for that secondary referral to specialists?
Okay. I think that will be helpful for a lot of centers participating in the learning community, so thank you. Vanessa, do you want to start on QI?
Sure. I guess your situation is somewhat unique in a way because on the one hand you've chosen to do this because you're afraid that, oh, I'm so sorry, the other practice will potentially close down. If they don't, so I guess why don't we talk about what you think your goals are if they do close down or if they don't close down. So the first one is if they do close down, I think what I hear you saying is that you want to be prepared to be able to handle all of their patients.
Yes.
Is that accurate? Okay. What's the time? I mean, do we have any idea of when they would know whether that's going to happen?
I think in the next 6 months.
Okay. Okay. And then if they don't close down, what would your goal be?
I have been corrected that they feel like that their funding is stable until 2015. But you know, one of the things he just said to me is that he's augmenting the Ryan White deficits with another program he started. So you know, they're really patching things together. So you know, who knows?
Okay. Okay, but they could very well over the next year. It sounds like they're not going to disappear in the next year. So meanwhile, you're doing this project with us, and so I'm wondering what your shorter-term goals would be. I mean, if you train providers but you're not actually providing HIV care for any patients, then you don't have any ability to practice what you're learning. So, and I know also at the same time you need to negotiate this politically. So we want to make sure we know, at least talk about your goal. You may not even know what it is, but we can talk a little bit right now so we have some idea of what we can also propose to you.
Well, I think our goal is to learn what are the resources in Florida, how do you build for these resources, and how do we educate a core team to be able to handle this disease within the primary care model.
Okay, and then I think you'd be learning how to educate the core team, but also getting the education itself from AETC. So do you envision potentially, rather than referring out, retaining some patients, maybe the homeless patients that have HIV, so that your providers can get some practice?
Possibly.
Okay. And if you didn't do that, what were you envisioning? I mean, maybe you were envisioning just the training with no practice.
That's what we were leaning towards, but I mean,
I think this is inevitable for us, ultimately.
Go ahead.
I mean, I think that the comprehensive health restructuring is inevitable ultimately. One, because of the funding issues that we've discussed with you, but also we mentioned that the people who are there, it's very individual specific, and without those two very powerful individuals running that organization, I don't know that there's anyone to pick up the torch here in this county, so that would be where we would step in.
Right.
We would not want to leave that population without resources, and so we need to be prepared, even if we're not actually seeing those patients. I think there's no way to avoid it down the road.
So it sounds to me like what we could do is work with you to decide, okay, you don't want to step on anyone's toes, but in the meantime, what small subset can you keep internally so that you can start building your HIV clinical care capacity? Does that seem appropriate?
Yes, and because we have such a good relationship with this organization, with Comprehensive Health, I would like them to participate in one of these phone calls and then sooner than later, because we can really, they can express their needs, and maybe they'll say it's 6 months, maybe they'll say it's 2016. You know, I think they know some of these answers even better than we do.
Right. I'm just thinking your opportunity right now is to get the clinical training, so I think you would need at least a few patients that you're working with. But we can, anyway, we have an idea of where you're thinking. Because a lot of what we do is predicated on that. For example, if you're starting to care for them, then we would be helping you figure out how to do registry and, you know, tracking viral loads and that kind of thing. If you don't have any patients that you're tracking that for, then we can't do that, which is fine because we want to tailor this to exactly what you want. But that's where my questions are coming from.
Well, they might share a patient or two with us so that we can start practicing that. I don't know.
Right. So I think that could be a discussion with them, and given your good relationship, then they would be open to coming up with something. It seems like you have a strong quality improvement structure and process. Are you interested? I mean, we always encourage that once you come up with your goals. So, for example, for some sites, they do want to go. I'm not saying you should. I'm just giving you an example. They want to, if they're foundational, they want to go with universal testing. It doesn't mean that they think everyone will test, but they want to track what percentage of people are doing the test and how many people are actually refusing, or potentially deciding which subpopulation to really concentrate on. That doesn't seem to be where you would focus, but are you interested, once we figure out who you're working with, in incorporating some measures into your quality improvement process for HIV?
Absolutely.
Okay. All right. So, so I think one of the things we can work with you on is really, yes, setting up your plan for how you're going to get practice. What are your measures that you'll be looking at? And then I noticed in the Plan, Do, Study, Act realm, you mentioned a HIPAA violation, and if you can just touch on that briefly so we can avoid any such problem with you in our work with you.
Help me. What do you,
well, maybe that was what you use the PDSAs around. I don't know. It says number 28 is, has your health center used the PDSA quality improvement methodology? It said yes. And then it said, please describe your experience. It was HIPAA violation assessment investigation. So maybe you can tell me a little bit about what you meant by that.
I'm not sure if you can see that question on your screen.
Our CEO has stepped away for a moment, and she's the one who wrote that. So we're just talking about.
Okay. Well, then, you know what? Let's skip that. I don't think it's that.
She just got information today in reference to that. So, yeah. Completely resolved. And it's been completely resolved, apparently.
Okay, but was it a HIPAA violation that occurred while running PDSAs on something?
Here, she's coming back. She can come
in. Okay.
What happened? This one thing we don't study yet.
Yes, actually we call it something else. I can't remember at this very moment. But are you asking about our expertise in doing focused, we call it focused PDS. Yeah, that's the same thing.
Yeah, I'm sure it's the same thing.
And are you asking, is that our standard?
Yeah, just if that's your standard, and in terms of how you test things when you're trying to make improvements.
Right. That's how we do it.
And then the HIPAA violation was something that occurred while you were running some PDSA, is that right? Or you were PDSA
because we had a HIPAA violation. We had a patient complain of their privacy being breached. So as part of the risk management and compliance protocol, we ran a process that looked at what were the preceding events, what were the influences, and
I see. Okay.
Response to the incident was, and how do we prevent it from occurring in the future?
Okay. Okay. And how would you say most of your staff is trained in how to do quality improvements using the Plan, Do, Study, Act model? No.
I think the administrative team is, but not most of the staff.
Okay. Okay, and I'm looking at the time, so I think Mazdak, I don't think I have any other questions here given our time frame.
Okay.
Do you have any?
Do you do any specific training on the process?
We do. Is that something that you would be interested in having for more of your staff?
Yeah, I really love to get our quality committee up to speed on all of that.
Oh, great. Okay. So I've made a note of that. Okay.
That'd be great. I mean, that's
yeah, and actually what we would, what our plan is, once we determine what your overall goals for HIV testing and treatment are, then we would plan to train your committee and whatever other staff members you want on PDSAs around running a PDSA on improving something in that realm.
That's
so then
fine.
we have a way to apply it immediately. It's not just training. Okay, good. So is there anything else under quality improvement that you can think of that you want support around?
Oh, I think that
no.
Okay, great. So Mazdak, I think you were going to cover the next section?
Yeah, so these are a bunch of sections around access that I'll try to go through quickly. For cultural competency, I know it sounds like this might be a new patient population for you all if you're starting to see more of these HIV positive folks. Have you done any sort of cultural competency with your staff around the populations most impacted by HIV or AIDS?
No.
Okay. Is that something that feels relevant?
Be very interested in that.
Okay. And do you all happen to know the prevalence or incidence in your particular county? What are the populations that are most impacted by HIV and AIDS in your county?
African American, Caucasian, and Hispanic.
Okay. And in terms of behavioral risk populations, is it
MSM.
And did I hear someone say IDUs too, or no?
Would you say IV drug use?
IV drug use, okay. Okay, and so in terms of the e-learning modules that you all provide for the staff, is that more general cultural competency, or have you all received anything on working with specific populations?
More general, but I think they do have something geared towards HIV/AIDS, so I have to look and see what exactly it is. But I think they do have something geared towards that.
Okay, great.
It's in our base module at this time because we've really just started with the e-learning process.
Gotcha. How are you all, how's that working for you all?
Well, we just started. We just purchased the program or the relationship mid-February and went live March 1st.
That's very new. Well, as we speak more, I would love to hear more about how that's working for you because I know a lot of folks are moving towards using those e-learning modules. So.
It's just so hard to keep training up as you get to be a certain size.
Yeah.
You have Centricity, right?
Yes.
Okay.
And in terms of the patient satisfaction survey, which one are you using? Do you have one that you made yourselves, or are you using the one recommended by NCQA?
Our own. Who does NCQA recommend? Press Ganey?
What is the name of the NCQA survey, Vanessa?
I think it is the Press Ganey that they recommend.
Press Ganey's great, but it's very expensive.
Okay,
we will double check that for you, but I'm pretty sure.
Yeah.
And you know that we are going for accreditation in both of those entities.
We did see that, yes. And we do have some experience as an organization working with folks around that. So as much as possible where it overlaps with HIV clinical work, we can provide you support around that as well. Do you know, so that patient satisfaction survey that you all have put together, does it ask questions about whether patients felt that their providers were culturally competent?
We don't have a question about cultural competency, do we, on our survey?
I don't think we did.
We don't.
Did we say we delivered the medicine to you in your native language?
But we say something that was a provider sensitive to your... Yeah, it's more general. It's not specifically cultural competency.
Okay. Well, in general, how have the responses to that question been, if you can...
About cultural competency?
Or about the way that you all phrased it.
Yeah, in our previous customer satisfaction, they felt like that it was delivered to them and met their cultural needs.
Okay. would you all be interested in taking a look at that and seeing if we can incorporate questions that would be particular to this population or could help assess cultural competency in different ways?
Cultural competency in general, definitely. Just HIV specific, it's such a small population, and it's already a lot for our patients to read. We'd be concerned that it would be too much.
Yeah. Okay. But look at it in a general sense then.
But if we take care of HIV patients, we could have potentially a separate questionnaire for them specifically.
Okay.
Because I think their needs are so unique. I think that would be appropriate, actually.
Yeah. But it sounds like the priority then for right now would just be more of, looking at that module around HIV and AIDS for your providers, and then maybe looking at something focused on the populations most at risk for HIV in your area.
Yes.
Okay. So moving on to recruitment and retention, I know that this is not something that you have necessarily been looking at in the past, but in terms of goals moving to the future and prepping for being in a place to see more folks with HIV, do you all feel like it makes more sense to focus on recruiting and identifying more people living with HIV, or linking them to care and retaining them to care? What makes sense as a first step?
Well, if we're really serious about getting these skills, you obviously have to use them. So I think we might be more interested in recruiting.
Okay.
Might I suggest? Sorry, Mazdak, I'm going to butt in here a little bit. I'm just thinking that in some ways maybe it's retention, because if you're looking at having some subset of people that you're serving so that you can get clinical care experience, then I think what you want to know is that that they're willing to come in to see you with the regularity that is necessary for treating HIV patients at whatever stage of the disease they're at. Whereas I don't know, it's just a suggestion. And Mona, are you still on the call?
Yeah, I'm sorry.
Yeah, what do you think about that? I mean, I'm not saying it has to be either or, but I'm thinking in their case, a good plan might be to come to agreement with the other organization so that they're not stepping on toes, and then having a population that they're going to serve, and then watching that they're able to treat the patients and keep them coming in at the frequency that's needed. And that would be more of a retention issue.
Right.
Does that seem right to you?
Seems like it could be. I mean, why is links not appropriate? Because they're so strongly linked already?
Yeah, I'm not saying they should do either or, but the main goal here for them right now is not to be like a recruiting away from someone else, but actually to gain experience treating, so that if they start to close down or start reducing how many they're serving, that Brevard will be ready to do that clinically.
I don't see any reason why they couldn't count the statistics from both groups. Use the. They don't have to take the patients away. You could count the patients that they're seeing together, regardless of where you test them. Do you know what I'm trying to say? Yeah, you could give them, quote, credit for no matter which of the two organizations they're being seen at, since they're working so closely together. Wouldn't you be able to?
Yeah.
Well.
Oh, that's true. So they could track retention, work with that other organization to track retention. Yeah.
It's really clear that their organizational linkage, if they have an MOA or whatever, there's no reason, I don't see any reason why we couldn't just consider the stats from both.
I see. Okay. All right. So that's probably something for further brainstorming and discussion with everyone.
Okay, so I wanted to do a time check. I know we're 5 minutes away from when we said we were going to end, and unfortunately we didn't get through all of our sections. But to recap what we've gotten so far in terms of potential priorities for our work with you all, in terms of revenue maximization, we heard about really getting more information about what's reimbursable in terms of care and different sorts of services and drugs, so that you all your providers will know what they're working with. In terms of quality improvement, we talked about incorporating HIV measures into your quality improvement work, but also spending some time around getting your QI committee all up to speed around PDSAs, or the way that you all do improvement work. And then finally, around access, we talked about potentially doing some cultural competency work around populations that are most impacted by HIV in your communities. And finally, we started getting some stuff around recruitment retention. I feel like we need to continue that discussion. But does that seem like a good recap of what we've discussed so far and good priorities to start with?
Yes. We're all in agreement.
Okay. Great, and so we are planning on, within our timeline is within the next couple of weeks, we'll put together what we've heard today and then try to have another call with your change team that's specifically going to be working around the performance improvement aspect of this. So
at that point, we're going to expand the base involved with this to have the rest of the team, correct?
Whoever will be working on the performance improvement side, right. So it's not necessarily the same as your clinical team, but yes. And then we'll work out a timeline and a plan for what the work will look like from now through December. And we might have to have, and we might have to have a little bit more conversation about what we didn't get through today.
What is in Washington? What is going to happen there?
So at the community meeting, sure. And at the community meeting, sorry, we were actually on the last slide. At the community meeting, we'll actually be working on your clinical training plans. You'll get a little bit more of an opportunity to talk to our sites. You'll get to meet us, network with some of the other sites, just give you a better sense of some of the things that we'll be required to do throughout the project. It'll really be a working meeting where you can really get your teeth into some of the things that we'll be doing throughout the year.
And you also have the opportunity to meet the other organizations that are participating, because this is supposed to be a learning community, and there's a lot you can learn from listening to other groups who are in similar situations to yours, and that you can share in terms of your own experience working with homeless, because I think we have at least one more group that has homeless as their main group.
Would you be willing to have someone from Comprehensive Health traveling with us?
Of course.
You would?
Sure.
Okay.
If they're going to be one of your key mentors.
Excuse me?
I mean, is it someone that you think you would be working closely with as a mentor, who would be working with you on your training?
Voice good.
Yeah. Well, I mean, I said yes right away. But I have to check with someone a little higher up than me who really is the decider. But I'm usually pretty persuasive, so let me just give you a sort of yes.
You know what? I'm going to make a call to once we hear from you, and I'm going to have you call Megan, if you will, because I'm going to be out of town next week. But once you give the okay, I will speak to her, and then, maybe you could talk with her about making the air arrangements.
Okay. Yeah, I mean, there probably going to be we're probably going to have to throw that all the way up to our funder, just because Comprehensive receives Ryan White funding for us.
Oh, yeah.
Yeah, well, we'll work it out. We'll see what we'll sort it out on our end, but it makes perfect sense in your case.
Okay, I think that would be really helpful for them to be part of the planning and feel like, they're engaged through this whole process.
Mhm.
Okay.
Okay. So, well, I guess we're on next up. It's 3 o'clock, so quickly we'll be in the next couple of weeks. We'll be assigning you a coordinator, a point of contact, essentially, for any of your general needs on the project. And then you'll also have a clinical coach as well as a coach on the performance improvement side. And you should again hear about those assignments in the next few weeks. again, we're having a follow-up call, specifically to deal with the clinical side, to talk about the training package and more in depth, and review the self-assessments so that you can begin sharing those with your care team members. And in quick and short, I think that's it. I'm respecting your time. It is 3:01. Do you have any quick questions for us? And actually, and I'm sorry, Vanessa, did you already present on the next steps before I took over? You did?
Yes. Yeah,
okay.
Unless you all have any questions.
Do you guys have any questions for us?
No, thank you very much. It was very helpful. Thank you.
Okay. All right, great. We look forward to working with you.
And we as well. Thanks.
All right. Take care. Bye-bye.
Bye.
And Vanessa and Master, do you want me to call back on which line?
You can call either, and we can conference the other person in.
Okay. I will do. All right, bye-bye.